Hello, I'm Roger Henderson. I'm a GP in southwest Scotland and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook, and you can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur all year round. Now in this episode we'll be discussing ectopic pregnancy, which arises when a fertilised egg implants outside the womb, most commonly in the fallopian tubes. Now, around 97% of these pregnancies are located in the tubal regions, with the majority of these being in the ampulla. Less frequently, ectopic pregnancies can occur in other locations, including the cervix, ovaries, peritoneum, or within a caesarean section scar. Now, in women undergoing IVF, around 1% may have a heterotopic pregnancy, where there are two concurrent pregnancies, one intrauterine and the other ectopic. In spontaneous conception, though, the incidence of this remains very low, at around 1 in 30,000. Now, in the UK, ectopic pregnancy is diagnosed in roughly 11 out of every 1,000 pregnancies. And despite improved outcomes over recent decades, it still leads to maternal death in approximately 0.2% of cases. And a salutary fact is that it appears 2/3 of these fatalities are actually linked to inadequate clinical care. Vulnerable groups such as recent immigrants, refugees, and women with limited English language skills are particularly at risk, often due to delays in accessing medical support. Now, the terminology for non-tubal ectopic pregnancies can sometimes appear confusing. For example, a cornual pregnancy refers to implantation in a malformed uterine horn, whilst interstitial pregnancy occurs in the part of the fallopian tube embedded within the uterine muscle. And interstitial pregnancies, although uncommon, are particularly dangerous due to a high risk of hemorrhage and the potential to be misidentified as normal intrauterine pregnancies during scans. Cervical pregnancies implanted in the lower part of the uterus, though, are extremely rare and often linked to previous uterine surgeries or intrauterine contraceptive use. Now, it may come as a surprise to you that more than half of diagnosed ectopic pregnancies are not associated with any known risk factors. But we do know that certain conditions significantly raise the risk of an ectopic, and these include smoking, a young age at first sexual intercourse, multiple sexual partners, a concomitant use of an IUD, prior fallopian tube surgery, exposure to diethylstilbestrol in utero, previous genital infections or pelvic inflammatory disease, infertility and in vitro fertilisation, a black race, and age over 35 at presentation. Now, as clinicians, we must all be alert to the possibility of ectopic pregnancy in any woman of reproductive age presenting with lower abdominal discomfort, even when typical symptoms are absent. And I've got a golden rule here, which is that any sexually active woman presenting with abdominal pain and vaginal bleeding after an interval of amenorrhoea has an ectopic pregnancy until proved otherwise. Now, symptoms generally appear 6 to 8 weeks after the last normal menstrual period, but they can occur much later in cases of non-tubal ectopic pregnancy. Common warning signs include pelvic pain, a missed period, and irregular vaginal bleeding. Other symptoms may include dizziness, shoulder pain, changes in bowel habit, or rectal pressure. And in advanced cases, particularly when rupture has occurred, signs of internal bleeding and shock may dominate, such as low blood pressure, rapid heartbeat, and pallor. Notably, internal bleeding may be significant even in the absence of visible vaginal blood loss. And atypical presentations may occur in cases of a ruptured ectopic pregnancy. So, for example, leakage of blood from the implantation site may irritate the diaphragm, leading to referred shoulder pain. Blood in the posterior cul-de-sac can manifest as a continuous urge to open the bowels, and lightheadedness may indicate severe hemorrhage and tubal rupture. Physical findings are sometimes normal, but they can include pelvic or adnexal tenderness, although an internal pelvic examination may sometimes be avoided in suspected cases due to the risk of provoking a rupture, especially when imaging is so readily available now. Diagnosing an ectopic pregnancy requires distinguishing it from conditions such as miscarriage, ovarian torsion, or appendicitis. But I found that in general, pain tends to precede bleeding in ectopic pregnancies, whereas the reverse is more typical in a miscarriage. And the bleeding in an ectopic is sometimes described as prune juice in character, but may be fresh blood, although heavy bleeding is relatively uncommon. Now, an accurate diagnosis depends on clinical assessment, hormone testing, and imaging. And a pregnancy test must always be done by either urine or serum human HCG testing in any woman of childbearing age who presents with abdominal pain. Transvaginal ultrasound remains the gold standard for identifying the pregnancy's location and assessing for embryonic development. And once pregnancy is confirmed by HCG testing, high-resolution transvaginal ultrasound is then used to determine the location of the pregnancy. It is possible to use transabdominal ultrasound here, but this is less sensitive and specific than a transvaginal one. Now, if a pregnancy can't be definitively located on ultrasound, but your clinical suspicion remains, then serial HCG measurements over a 48-hour period are very helpful. A suboptimal rise, less than 63%, or a fall, less than 50%, in hormone levels strongly indicates a non-viable pregnancy and warrants urgent follow-up. But do remember that a single HCG cannot differentiate between an intrauterine and an ectopic pregnancy, and that as a general point, all pregnancies should be considered potentially viable until they are diagnosed as not. I think it's also worth mentioning here that in up to a third of cases, neither an intrauterine nor an ectopic pregnancy can be visualized on ultrasound. And you may have heard that in these cases, the descriptive term pregnancy of unknown location, or PUL, is used. You may also have heard that progesterone has been used in many studies as an adjunct to diagnosis for ectopic pregnancy, and it is the case that progesterone levels can sometimes be useful in indicating the viability of a pregnancy. However, the UK Royal College of Obstetricians and Gynecologists advises that a serum progesterone level is not useful in identifying ectopic pregnancy, and it's also not listed as a recommended investigation for tubal ectopic pregnancy by the American College of Obstetricians and Gynecologists. Now, treatment decisions hinge on factors such as the woman's clinical condition, the size and site of the ectopic pregnancy, and HCG levels. But my usual practice is to admit any patient for further investigations. The Royal College of Obstetricians and Gynecologists say that expectant management is an option when a decreasing HCG level is initially less than 1500 international units per litre, and in women with an initial HCG less than 200 international units per litre, over 80% will have spontaneous resolution. Now, NICE has also made a strong recommendation for expectant management if the serum HCG is less than 1,000 intrauterine international units per litre, but a conditional recommendation for expectant management if the serum HCG is between 1,000 and 1,500 international units per litre. Now, medical management using methotrexate is effective in many early cases, as this is a folic acid antagonist that disrupts rapidly dividing trophoblastic cells. Now, its use here is reserved for hemodynamically stable women who have a confirmed or high clinical suspicion of an ectopic pregnancy, an unruptured mass, and no absolute contraindications to methotrexate. And both the RCOG and NICE state that a good candidate for this treatment would have an HCG ideally less than 1,500 international units per litre, but this can be up to 5,000, and no fetal cardiac activity on an ultrasound scan with certainty that there is no intrauterine pregnancy. Now, a single dose regime of methotrexate may be an appropriate choice for women with a low initial HCG or plateauing values, and a 2-dose regime is an alternative which may be particularly suitable for women with an initial high HCG. Once methotrexate has been given, HCG levels should be serially monitored until they reach a non-pregnancy level, and this usually takes 2 to 4 weeks, but it can be a little longer, and further doses of methotrexate may be needed depending on the regime and the response to treatment. Now, if at any time the patient becomes clinically unstable, surgical intervention is indicated. During methotrexate treatment, all vigorous activity and sexual intercourse should be avoided, as this may potentially cause a rupture of any ectopic. And due to its teratogenic effects, contraception is recommended for several months after its use. Now, surgical treatment is reserved for women with significant symptoms, large ectopic masses, high HCG readings, or signs of internal bleeding. The preferred method here is laparoscopy, with either salpingostomy or salpingectomy, depending on the status of the contralateral tube and the desire for future fertility. Now, there's no evidence to recommend salpingostomy over salpingectomy if the contralateral tube is normal. NICE also recommends anti-D immunoglobulin for all rhesus-negative women undergoing surgery for ectopic pregnancy, but not for those being treated medically. Following medical or surgical treatment, all women should be reviewed weekly and serial HCG levels taken until these are less than 10 international units per litre. If these levels don't decline, the woman can be treated with a second course of methotrexate or with a post-surgical course of methotrexate, following which weekly serial HCGs should still be done until the level is below 10 international units per litre. Once serum HCG levels are undetectable, then no further monitoring is needed. Now, expectant medical and surgical treatment success rates are of the order of 80%, 90%, and 92% respectively, and ectopic pregnancies are now identified early in more than 85% of cases, thanks to improved awareness and diagnostic technology. The rate of recurrent ectopic pregnancy is between 5 to 20%, but this can rise to up to 30% in women with 2 consecutive ectopic pregnancies. Despite this, the chances of having a future successful pregnancy still remain generally favourable. Fertility and tubal patency rates in laparoscopically treated women are similar to those who are medically managed. So that was a very quick clinical overview of ectopic pregnancy, and I do hope you find the podcast helpful the next time you see a patient with this condition. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.